Hello and welcome to Abnormal Psychology, Clinical Perspectives on Psychological Disorders. Today we will be reviewing Chapter 2, which is on Diagnosis and Treatment. And this is from the author Susan Krauss Whitbourne and publisher McGraw-Hill. First of all, we're going to look at diagnoses from the experience of the client and the clinician. So the patient is a person who receives treatment, whereas when referring to a client, it's a person that's seeking psychological services. This language reflects the view that people in treatment collaborate with those who treat them rather than as a passive recipient. The clinician is the person that provides the actual treatment. There are different types of clinicians. There are psychologists, which are healthcare professionals that offer psychological services. Psychiatrists have a degree in medicine, they're MDs, and they specialize in training that is specific to psychological disorders. And then clinical psychologists are licensed psychologists who are mental health professionals that are trained in behavioral sciences and provide direct services to clients. So you can have a degree in organizational psychology, but you're not going to be a clinical psychologist. To be a clinical psychologist, you would have to have a degree in clinical psychology as well as pass some exams and be licensed. Usually in the field, psychiatrists are the ones who perform medicine management, and the clinical psychologists are the ones who provide testing services. There are a few clinical psychologists who do their own therapy, but a lot do testing services. There's two types of doctorates in psychology. You have the doctorate of philosophy, which is a PhD, and the doctorate of psychology, which is a PsyD. I believe here in San Antonio, it is St. Mary's that offers the PsyD degree. There are also professionals with master's degree that provide psychological services. And for instance, for the licensed professional counselors, they're allowed to do psychological testing as long as they can prove that they have been trained in it. But they are not allowed to do subjective testing, such as the Rorschach. So your master's level providers are social workers, master level counselors, marriage and family therapists, nurse clinicians, and school psychologists. So looking at the diagnostic process, this is a systematic approach to classifying the disorders that clinicians see in their clients. A diagnostic manual serves to provide consistent diagnoses across people based on the presence or absence of a set of specific symptoms. Because if you don't have an accurate diagnostic manual, it's impossible to come up with the best treatment plan for a client. We all need to be using the same terminology and meaning the same thing when we use that terminology to be able to accurately communicate about the care of a client. Reliability is when we're using this terminology in regards to diagnosis to the degree to which clinicians provide these diagnoses consistently across individuals with a particular set of symptoms. And validity would be the extent to which a test, a diagnosis, or a rating accurately and distinctly characterizes a person's psychological status. So validity is doing what it's supposed to do. Reliability, it doesn't on a consistent basis. So the Diagnostics and Statistical Manual of Mental Disorders, and we're on version 5 now, is a book published by the American Psychiatric Association that contains standard terms and definitions of psychological disorders. Before version 5, there was an axle system. Now it's a non-axle diagnostic system divided into 22 chapters of sets of related disorders. So an axis is a class of information in previous DSMs regarding one dimension of an individual's functioning, whereas the multi-axle system is a multi-dimensional classification diagnostic system in previous DSMs summarizing relevant information about an individual's physical and psychological functioning. And I'm going to show you what that axle system used to look like. So if you can see here, it's a little small. Used to, before the DSM-5, there were 5 axes. The first axis is where you would list someone's clinical disorders, such as major depression. Axis 2 were your personality disorders, such as borderline personality disorder. Axis 3 were any type of general medical disorders, like if someone had diabetes. And then Axis 4 were psychosocial and environmental factors. So if there were family problems, homelessness, things along those lines, those environmental type factors. And then Axis 5 was the global assessment of functioning. And the global assessment of functioning is also called the GAF score. Here is a picture of the global assessment of functioning that was included in the 4th edition of the DSM. But as you can see here, you would have to actually read through and look at examples of the level of functioning of someone to figure out what their GAF score was. The lowest GAF scores are in persistent danger of severely hurting self or others. So there has been recurrent violence, or the persistent inability to maintain minimal personal hygiene, or serious suicidal acts with clear expectations of death. And then as you go towards the middle, serious symptoms such as suicidal ideation, severe obsessional rituals, frequent shoplifting, or serious impairments in social, occupational, school functioning. And then at the higher end, you have superior functioning in a wide range of activities. Life problems never seem to get out of hand. This person is sought out by others because of their many positive qualities, and there basically are no symptoms. So you would have to kind of figure out where on the scale someone fell for their global assessment of functioning. When the DSM-5 was created, there were several goals to try to remedy some issues that clinicians saw in the previous versions. One was that they wanted to decrease the reliance on not otherwise specified, or NOS, diagnoses. So a lot of times if someone does not meet the specific criteria, there was a catch-all diagnosis at the end that would be not otherwise specified. So it meets these, but not exactly. And so in most areas of psychopathology, these NOS diagnoses were the most common ones that were being given. A second goal was to add dimensional measures of symptoms and severity. So problems that are frequently encountered with categorical diagnoses include high rates of comorbidity, which means there are different diagnoses existing at the same time, frequent use of these NOS diagnoses, and a boundary line between the disorders drawn on the basis of tradition rather than really empirical data. Another goal was to better align the DSM with the World Health Organization's International Classification of Diseases system, otherwise called the ICD. We are currently on version 11 that was released in approximately 2018. The DSM-5 was released approximately in 2015. The last goal was to update the manual to reflect current scientific evidence. The DSM-4 had about 160 diagnostic categories, with 201 categories being defined by using diagnostic criteria, whereas the DSM-5 had way more diagnostic categories. They had 541. However, only 151 of those categories were defined using diagnostic criteria. So it cut down on that level. Most mental health professionals outside of the United States and Canada use the ICD-11 system. 10 was the current edition when this book was published, but 11 is now out as of 2018. The advantage of using it is that it provides a common diagnostic system to be able to compare diseases across 110 member nations for epidemiological purposes. So this helps to increase consistency of diagnostic terminology across various countries. Now I've listed a link here that you can go and actually look at the website for the ICD-11. In your textbook, there is also a list of the 22 categories of related disorders as presented in the DSM-5, and they are listed by how closely they are related to each other, how closely the categories of symptomology are related. Psychosocial factors can also be found under the DSM-5 and the ICD-11. Under the DSM-5, they're referred to as V codes, and under the ICD-11, they're referred to as Z codes. And these are other conditions that may be a focus of clinical attention. So these can be problems with psychosocial issues, environmental problems, whether someone has a support system, whether they're homeless. These are things that can affect the outcome of treatment and need to be taken into account when providing care for somebody. Here are some examples of Z codes in the ICD-10. Problems related to education or literacy could be underachievement in school, problems related to employment or underemployment, change of job, sexual harassment on the job, military deployment, related to housing, economic, homelessness, poverty, low income, problems related to social environment, acculturation difficulties, other problems related to primary support group, including family. So there could be problems with the spouse, disappearance or death of a family member, alcohol or drug addiction in the family, and then problems related to certain psychosocial circumstances such as an unwanted pregnancy. The World Health Organization Disability Assessment Schedule is something that can be included in a clinician's overall judgment of a client's psychological, social, and occupational functioning. An instrument that is known as the World Health Organization Disability Assessment Schedule, or the HUDAS, is included in a section of the DSM-5 so that clinicians can provide such a rating. And here is a view of the HUDAS to give you an idea what it looks like. Ask people in the last 30 days, how much difficulty have you had in? And they will rank between none, mild, moderate, severe, extreme, or cannot do. And you've got concentrating on doing something for 10 minutes. So this is all coming under the category of understanding and communicating, remembering things, solutions to problems. You've got another category on just getting around, standing up, moving, getting out of your house, walking, self-care, washing, getting dressed, eating, staying by yourself, getting along with people, maintaining friendships, new friends, sexual activities, life activities in the household, like taking care of household responsibilities, life activities such as school and work, your day-to-day work in school, how much difficulty have you had being able to stay on task, getting work done, getting it done as quickly as needed. And then participation in society, joining in community activities. Have you had any barriers or hindrances? Have you been living with dignity? How much time did you spend on your health and consequences? Have you been emotionally affected? Drain on financial resources? How much problem did your family have because of your health problems? And how much of a problem did you have in doing things by yourself for relaxation and pleasure? So you can see that's here, and then the clinician will score it on the side, and it walks you through how to actually score this scale. So I just wanted to give you a picture of kind of what it looks like. There are also culture-bound syndromes that need to be kept in mind. These are recurrent patterns of abnormal behavior or experience that are limited to specific societies or cultural areas. Cultural concepts of distress are ways in which individuals in specific cultural groups experience, understand, and communicate their suffering, behavioral problems, or troubling thoughts and emotions. Here are some examples of cultural syndromes. The problem is clusters of symptoms and attributions that tend to occur among individuals in specific groups who share the same culture. An example is the ataque de nervios, a syndrome among people of Latino descent reflected in such symptoms as intense emotional upset, aggressive behaviors, and fainting episodes. An example of cultural idioms of distress, ways of expressing distress in a particular cultural group, such as the kungfungia, meaning thinking too much, among the Shona of Zimbabwe, referring to depression, anxiety, and physical symptoms. And then cultural explanations or perceived causes, how people in the culture label or attribute causes to symptoms, illness, or distress. An example would be the DOT syndrome, the belief among South Asians that semen loss causes diverse symptoms in young men such as fatigue, anxiety, weight loss, and depressive moods. These are things that have to be taken into account, because if you're diagnosing someone based on a belief that is counter to the culture in which you are existing in right now, it is not fair if this is something that is coming from a culture that they have been immersed in. Cultural factors that need to be considered are race, religion, immigration status, relationships with family and community as potential sources of symptoms, but also as sources of support. So a principal diagnosis is the disorder that's considered to be the primary reason someone's seeking help. A differential diagnosis is the process of systematically ruling out alternative diagnoses. And comorbid is when the situation occurs when multiple diagnostic conditions occur simultaneously in the same person. For example, you can have major depression and obsessive compulsive disorder at the same time. As you will see as we start getting into the DSM and the diagnostic criteria, a lot of the time you are spending time ruling out possible diagnoses to determine an accurate diagnosis of the person's symptoms. The clinician develops a case formulation, which is an analysis of the client's development and the factors that might have influenced the person's psychological status. The case formulation transforms the diagnosis from a label and a set of diagnostic code numbers to a more elaborate piece of descriptive information about the client's personal history. This case formulation helps the clinician to better design and individualize a treatment plan. Cultural norms and beliefs have a strong impact on clients who strongly identify with their culture of origin. Cultural background needs to be considered when interpreting symptoms. Different cultures attach significant meanings to a particular event that would signal the playing out of a culturally influenced scenario instead of a disturbance within the individual. In treatment planning, the treatment plan should describe the person's immediate goals in terms of what needs to take place now, short-term goals, and long-term goals. It should also describe, in addition to the treatment goals, the treatment site, the modality of treatment, and the theoretical approach that's going to be used in the delivery of treatment. So different sites are psychiatric hospitals or specialized inpatient treatment centers such as recovery centers. You also have outpatient treatment centers, which can be called partial hospitalization programs that are usually 8 to 5-ish, or in an intensive outpatient program where it's just a couple hours a day, or they may be a couple evenings a week. You have halfway houses and day treatment programs, as well as other sites such as the workplace, employee assistant programs, and schools that treatment is provided within. The modality of treatment is the form in which the clinician offers psychotherapy. So is it an individual psychotherapy or counseling in which you're working one-on-one with the client? It can be family therapy where you work with several members of a family or the entire family. Group is where you facilitate discussion among several different clients who will talk together about their problems. And then milieu therapy, which is a treatment approach used in inpatient psychiatric facilities in which all facets of the milieu or the environment are components of the treatment. Treatment plans are and should often be revised as treatment progresses and the treatment is evaluated. Usually in psychiatric hospitals, they review treatment plans each week and update them. There are 6 major theories and approaches that we will be looking at throughout the book. The first one is behavioral, and in the behavioral perspective, it holds that people engage in problematic thinking and behavior when their environment supports it. You have behavioral therapy that will fall under this category. And then under cognitive, this holds that the people experience psychological and emotional difficulties when their thinking is out of sync with reality. And you've got cognitive behavioral therapy, cognitive processing therapy, and rational motive therapy that will fall under that category. Under humanistic, this perspective holds that people have within themselves all the resources they need to live healthy and functional lives, and that problems occur as a result of restricted or unavailable problem-solving resources. Psychoanalytic holds that psychological problems result from the present-day influence of unconscious psychological drives or motivations stemming from past relationships and experiences. Constructionists hold that knowledge is merely an invented or constructed understanding of actual events in the world. And systemic holds that thinking, feeling, and behavior are largely shaped by pressures exerted on people by the social systems from which they live. The systemic view is what is common in social work fields. In the field of psychology, the goal is to use evidence-based practice. You want to be using modalities, treatment options that have been found to be effective.
So clinical decision-making integrates the best available research evidence and clinical expertise in the context of also looking at cultural backgrounds, preferences, and characteristics of clients. It is very difficult to do research on therapeutic techniques because even within the same field or specialty or perspective, clinicians can use the theory and integrate it into how they interact with the client in very different ways. So to measure that is difficult because it's different across different clinicians. There is research that's being done through a grant called the Strong Star Initiative that is affiliated with UT Health Science Center, in which they have created a cognitive processing theory that is based on cognitive behavioral therapeutic techniques. However, they've made it very prescriptive, and when they train clinicians, they have to go by the number. Session 1 you do this, session 2 you do this, these are the handouts you use. It's very prescriptive so that they can then do research on whether or not the effects of that treatment are reliable and valid, that it's measuring what it's supposed to. If you're interested in that, you can always go to UT Health Science Center and look up that research. So in the course of treatment, the clinician's role is to develop rapport with the client, to develop a relationship in which the client can depend upon. And at the same time, it's not that you just totally agree with somebody, but they know that you're going to tell them the truth, whether it's something they want to hear or not, but that they can trust you regardless of whatever they tell you. You're not going to turn them away because of what they tell you. The client's role in treatment is a joint enterprise in which the client plays an active role. The therapy is going to be based off what they provide in the sessions for you. So if they don't give you or divulge the information that is needed to work with, that is not going to allow them to get the most out of therapy. So they have to be able to really trust their clinician in order to feel safe enough to divulge information that they may not feel safe divulging. In terms of outcome of treatment, of course, the ideal outcome is that the person no longer has any interfering symptoms. So that is the goal. A lot of times people have to learn how to manage their mental health issues or addiction issues, and it's a lifelong process. However, there is a lot of support out there for people to utilize so that they can manage it in a manner that doesn't impede them having a healthy and happy life. I hope this was helpful. Thank you and have a wonderful day.